My name is Elizabeth Folkman, and I'm an adult rheumatologist at the University of California, Los Angeles, where I care for patients who have autoimmune interstitial lung diseases. I'm delighted to share with you today the learning objectives for this talk. The first objective is to recognize diseases most commonly associated with progressive pulmonary fibrosis. The second objective is to identify the signs and symptoms of progressive pulmonary fibrosis, or PPF, to improve diagnosis in accordance with updated guidelines. So we'll begin with a case. And just as a background, fibrosing interstitial lung diseases encompass a number of diverse conditions, overlapping in their clinical presentation, imaging, and histopathological patterns. So you can see from this figure here, idiopathic pulmonary fibrosis, or IPF, is the prototype of a fibrosing ILD that generally gets worse over time or progresses. But a significant proportion of patients with fibrosing ILDs other than IPF will develop a progressive fibrosing phenotype. And these are exemplified by these different circles here. So they include things like sarcoidosis, drug-induced ILDs, connective tissue disease-related ILDs, etc. There's been a lot of terminology to describe this type of clinical phenotype in the literature. So progressive fibrosing ILDs has been used, ILD with a progressive fibrosing phenotype has also been used, as well as chronic progressive fibrosing ILDs. And historically, there's been no unifying definition, including in clinical trials where different clinical trials have utilized various criteria to define this progression in ILD. But finally, in May of 2022, there was an International Society Practice Guideline update. And in this guideline, they provided unified terminology for this type of clinical phenotype. And they called it progressive pulmonary fibrosis and provided a consensus definition with both radiological, physiological, as well as symptom criteria, which I'll describe in the next slide. So this is the definition of progressive pulmonary fibrosis, or PPF, that was proposed. So it really applies to a patient with ILD other than IPF who's had evidence of disease progression. And so they have to have at least 2 of the 3 criteria occurring within the past year with no alternative explanation. So the first is respiratory symptoms that are getting worse. The second is physiological evidence of disease progression, and this could be an absolute decline in the forced vital capacity greater than or equal to 5% predicted within the previous year, or an absolute decline in the DLCO corrected for hemoglobin greater than or equal to 10% in the previous year. And then finally, radiological evidence of disease progression. So 1 or more of the following suggesting radiologic worsening in the extent of ILD. So again, progressive pulmonary fibrosis patients have to have at least 2 of the 3 criteria in the previous years. And in terms of the prevalence of PPF across various ILDs, in fact, many ILDs can have progressive pulmonary fibrosis. So in this slide here, which came from that consensus paper, you can see that each disease has shading, and the proportion of patients with ILDs who manifest PPF is basically represented here by the degree of shading. And this was basically decided based on expert consensus. So you can see for a disease, for example, like systemic sclerosis under the autoimmune ILD category, they estimate that about half of all patients with SSc will have progressive pulmonary fibrosis. And then the prevalence, from actual data, again, because that previous slide was based on a consensus statement, there have been studies and recent data from Canadian and Japanese cohorts which use slightly different criteria for PPF, also demonstrated that many patients with these different types of ILD can have progressive pulmonary fibrosis. So for example, in both of these international cohorts, approximately 60% of the patients with IPF met their criteria for progressive pulmonary fibrosis. In the connective tissue diseases, they were slightly different, with 45% of the Canadian cohort patients and 27% of the Japanese cohort patients respectively meeting the criteria for progressive pulmonary fibrosis. And I think what's important to take away from these two slides is that progressive pulmonary fibrosis can occur in various ILDs, and this is why it's important to monitor for a progression of ILD regardless of the underlying cause of the ILD. So let's move into a case, and this is one of my patients, a 50-year-old Caucasian female who initially presented to me for evaluation of systemic sclerosis in 2016. But her medical history started much before this time. So in 2004, she developed carpal tunnel syndrome. A year later, she developed Raynaud phenomenon. And then in 2008, she had a chest x-ray during a routine physical, which demonstrated interstitial lung disease. And this is not uncommon for ILD to be diagnosed incidentally on routine chest x-ray. So the patient was referred to a pulmonologist a year later who recommended a surgical lung biopsy. The biopsy demonstrated usual interstitial pneumonia. And at that time, the patient was very active. She had been running marathons, so treatment was deferred. And the decision was made by this outside pulmonologist to just monitor the patient every 6 months, assessing her symptoms and pulmonary function tests. For the next 7 years, she just had monitoring. But also things that I gathered was that in 2010, she had been diagnosed with Barrett's esophagitis and underwent ablations. And then over the course of about 2012 to 2016, she started to experience dyspnea. And keep in mind, this patient had been running marathons, so her dyspnea really just occurred when she would go on long runs. And then in 2016, she decided to refer herself to a rheumatologist after reading about scleroderma online and trying to connect the dots for why she was having these esophageal symptoms as well as the Raynaud's. So when she came to see me, her symptoms included dyspnea on exertion, dry cough, heartburn, as well as fatigue. On physical examination, she had bibasilar crackles, telangiectasias on her chest. She also had sclerodactyly, which means thickening of the skin of the fingers, and her modified Rodnan skin score, MRSS, was 2. And this is the way that we objectively assess the extent of skin involvement in patients with scleroderma. So in terms of her serologies, she was found to have a positive ANA at a titer of 1 to 160, and the pattern was homogeneous and speckled. And most patients with systemic sclerosis will have a positive ANA antibody. But she was negative for the centromere antibody, SCL70, which again is associated with an increased risk of progressive pulmonary fibrosis, and also negative for the RNA polymerase III antibody. Her pulmonary function test that we obtained during her visit in 2016 demonstrated an FVC of 79% predicted and a DLCO of 55% predicted. But I looked back at her pulmonary function test trends over the previous years because, again, remember, she had been followed by this outside pulmonologist. So if you look at the blue line here, which represents her forced vital capacity, you can see from the time of her diagnosis in 2009 to the time that I was seeing her in 2016, there really wasn't a change in her FVC. However, if you look at her DLCO is declining, albeit slowly over this time period. And this is not unusual to see in patients with ILD, where early in the course of the ILD, the FVC can remain stable, but patients can have declines in their DLCO. And this is why it's important to get both the FVC and the DLCO measured serial in your patients to assess for progressive pulmonary fibrosis. In terms of her CT imaging, while I wasn't able to access her CT back from 2009, I did find a CT from 2013. And in this CT, what you can see is that this patient has reticulation, which is represented here by this top red arrow. And these are these fine white linear opacities that we think represent fibrosis or scarring in the heart. She also has what's called traction bronchiectasis, and this is represented by the middle arrow. And what this means is that when patients get architectural distortion and fibrosis in their lung parenchyma, this can pull on the airways and elongate them. And then finally, this patient had ground glass opacity, and this is represented by this hazy gray opacity where you can still see the blood vessels through, but it's not normal black space, which represents air. In 2016, we got repeat CT imaging, and this CT showed worsening reticulation or fibrosis. And you can also see this patient is starting to develop honeycombing, which is more of an end stage sign of interstitial lung disease. So we decided to treat this patient since she was progressing, and we started her on mycophenolate, which is not an FDA-approved treatment for SSc, but considered a first-line agent by experts because it's been demonstrated in clinical trials for SSc ILD to improve lung function, radiographic fibrosis, as well as self-reported dyspnea. We also referred this patient to pulmonary rehab. A year later, she started a clinical trial for SSc ILD, and this trial allowed her to remain on mycophenolate, but she was randomized to abatuzumab, which was an investigational agent, versus placebo. But the trial stopped prematurely on account of the sponsor, so the patient after this time just remained on the mycophenolate. And looking at her PFT trends, so if you look at these later time points from when I first started seeing her in January 2016 to May 2017, you can see that the initiation of mycophenolate led to stabilization of her DLCO, and her FVC continued to remain stable. So we perceived this as a sign that the mycophenolate was working for her. In terms of her symptoms, she also reported that her dyspnea had improved, and really she was only getting short of breath with fast movements. Her acid reflux or GERD was better controlled when we started her on a proton pump inhibitor, but she was still having a cough in the mornings. And her serial PFTs and interval HRCT had been stable. Then the pandemic happened, and during 2020 to 2021, she really didn't report a change in her dyspnea, but she stopped exercising like many people did during the pandemic for various reasons. And she started to note worse cough, and this cough was affecting her quality of life, and she became sometimes embarrassed to be out in public because when she would cough, people around her would think that she might have COVID. And she was really afraid of coming into the hospital, so she declined to get any pulmonary function tests, CTs, or even echocardiograms during this time period for fear of getting COVID. And then she eventually did get COVID, like most people during the pandemic, and she got it in August 2020. She had mild symptoms. She did not require hospitalization. And even after getting COVID, she still did not want to come in for testing. Finally, testing resumed in May of 2021, and we obtained pulmonary function tests, and she had an interval decline in both her FVC and DLCO. Her cough was worse, and per her husband, she was more sedentary than ever, and we scheduled a CT of her chest. So this was her CT imaging from 2021, and you can see there's been marked change compared with the one that we obtained in 2016. What you can see here is this patient has worsening fibrosis and now has much more extensive honeycombing. And what you'll also notice here is that it's in an asymmetric pattern, meaning that on one side of the lung, there's more fibrosis or honeycombing than the other. And we see this not uncommonly in patients with a UIP pattern. So again, she resumed her testing, and she had a decline in her pulmonary function, worsening symptoms, decreased exercise, as well as radiological progression on her HRCT. So in this case, we decided to start combination therapy. And we kept the patient on mycophenolate because on a few occasions, the patient had stopped mycophenolate for various reasons, like getting a cold. And whenever she went off of it, she reported feeling more fatigue. So we kept the patient on the mycophenolate, but we started the patient on nintedanib. And studies have demonstrated that this combination of mycophenolate and nintedanib can slow the decline of the forced vital capacity. She did develop some diarrhea on the nintedanib, so we reduced the dose, and she was able to tolerate this lower dose. And her follow-up PFTs about 6 months after starting combination therapy showed stability. One thing to highlight that's important in this case is the multidisciplinary discussion. And this was missing when this patient was first diagnosed with her ILD. And had it been done, it might have changed the course of her treatment. So, what is an MDD? Well, core MDD participants include pulmonologists, rheumatologists, radiologists, as well as pathologists. But other participants may include respiratory therapists, psychologists, as well as social workers. And there's been a number of studies demonstrating the benefits of the MDD process in patients with ILD. So these studies demonstrate increased diagnostic confidence by refining a provisional diagnosis, increased diagnostic precision, as well as enhanced inter-observer agreement on the diagnosis. Education is also a critical aspect of caring for patients with progressive pulmonary fibrosis. And in surveys of patients with IPF, progressive ILD, these surveys has found that information about disease progression and what to expect is at the top of the list of educational needs. Patients want to do their own research and use preferred websites as their primary means of acquiring disease-related information. But there are concerns about where to find trustworthy information. And recent studies have found that information on the internet is often inaccurate, incomplete, and outdated. And I find this a lot in caring for patients with systemic sclerosis-related ILD, where a lot of the studies on life expectancy and mortality outcomes for patients with ILDs are based on very old studies before we even had treatments approved for this condition. But there are some reliable resources available, and they include the Pulmonary Fibrosis Foundation, as well as Pinpoint Pulmonary Fibrosis, and the websites are listed here. So in terms of the reflections on this case, I think one thing that's important to highlight is, again, this patient didn't undergo a multidisciplinary discussion, and she was followed for years by an outside pulmonologist who missed the scleroderma diagnosis. And this can happen. This patient had limited skin disease, so it maybe was not so obvious that they had scleroderma compared to someone who might present with more diffuse skin disease. Also, the UIP pattern is not the dominant pattern that we see in patients with scleroderma ILD. Usually we see an NSIP pattern, but studies that have estimated that about a quarter of patients will have a UIP pattern. So just because someone has a UIP pattern does not preclude them from having systemic sclerosis-related ILD. In addition, this patient had a slow decline in lung function. And so if you were just looking at her FVC from visit to visit, there really wasn't a significant change. But it's really tracking these changes over time that allows you to see that her DLCO was declining and she was having physiological progression. And then also the exercise tolerance. Her decline in exercise tolerance was gradual. And remember, she started out running marathons. So even to the point where she was starting to notice more dyspnea on exertion, she was still probably able to do more than the average patient because she started out at this place of being able to exercise quite a lot. So when asking your patients about exercise tolerance, it's important to establish the right baseline for them. And again, in this patient, she started out running marathons. So by the time she saw me 7 years into her disease, when she couldn't run anymore, she was still able to walk and walk upstairs and up hills, but she had had a decline in her individual exercise tolerance. Again, if a rheumatologist had been involved earlier on, this may lead to a different outcome for this patient. She may have had an earlier diagnosis of scleroderma, which could have enabled her to receive other treatments for scleroderma to address the other clinical manifestations of the disease. And progression of SSc ILD can occur early, but it can also occur patients with a slowly progressive phenotype at later disease stages. So in this patient, she was experiencing progression beyond that 5-year time point when people think that these patients generally don't have progression. I want to thank you for your time today. Please remember to complete your post-test and evaluation for CME credit. Thank you to Boehringer Ingelheim Pharmaceuticals, Inc. for providing the educational grant to support this program. And please visit this website here, pilotforpulmonary.org, for more CME opportunities.